Hello and welcome to PharmaZ's very first pharmacy teaching video. This video is going to be about neurotherapeutic index drugs, and that's based off your requests on Instagram. So without further ado, let's get started. Neurotherapeutic index drugs are medications in which the therapeutic level is very close to the toxic level, so they require therapeutic drug monitoring to ensure that the patient's plasma drug levels are within the therapeutic range. The main ones are Carbamazepine, Digoxin, Gentamicin, Lithium, Phenytoin, Theophylline, Vancomycin, and Warfarin. These form part of the high-risk drugs which are assessed in the GPHC exam, but these specifically are the neurotherapeutic index drugs. So let's start off with Carbamazepine. Its therapeutic range is 4 to 12 mg per litre, and that's usually achieved after 1 to 2 weeks. It's an anti-epileptic drug which requires maintaining the same brand and is therefore a category 1 anti-epileptic, and it's eliminated by the liver. It's really important to know the route of elimination of different drugs because this usually gives away the interactions, the side effects, and the monitoring for the drugs. Interactions include interacting with clarithromycin and erythromycin, and they inhibit the metabolism of carbamazepine and therefore increase the levels. And phenytoin induces the metabolism of carbamazepine and therefore reduces its levels. The macrolides interaction is a very common interaction that happens with a lot of drugs. Monitoring includes full blood count, renal function tests, and liver function tests. And it's important to know what you need to monitor, as this usually gives away what the serious side effects are or the toxic effects are that a patient might get whilst on a drug. So if you're monitoring these parameters, you're likely to pick up on toxic effects sooner and when they're less serious. Warning signs include blood disorders. So a patient may present with fever, sore throat, mouth ulcers, unexplained bruising or bleeding, and these can be signs of thrombocytopenia due to bone marrow suppression. Skin disorders such as toxic epidermal necrolysis, and the patient may present with rash or mouth ulcers in that case. Hepatic disorders such as hepatitis. Anti-epileptic hypersensitivity syndrome, in which a patient may present with fever, rash, and swollen lymph nodes. Therefore, this overlaps with a few of the other disorders. And other toxicity effects. These could be eye-related, including nystagmus, which is involuntary eye movements, diplopia, which is double vision, blurred vision, as well as incoordination, ataxia, and hyponatremia. In terms of driving, the DVLA sets out its guidance. So you have to be seizure-free for 1 year. If a patient gets attacks, these should be sleep attacks and not awake attacks, and established over a 3-year period. And if a patient is being withdrawn from medicines or there's dose changes, they should avoid driving for that period and 6 months. Moving on to Digoxin, which is used in the treatment of heart failure and atrial fibrillation. Its therapeutic range is 1 to 2 micrograms per litre, although toxicity can occur between 1.5 to 3 micrograms per litre, and the elderly are more susceptible to toxicity. Levels are taken 6 hours post-dose, and loading doses may be required because the response takes many hours to occur. It's once daily dosing as it has a very long half-life. However, you might see some patients be put on it twice daily, and that's because they're experiencing side effects, so the dose is split. It's renally excreted, and the renal function actually determines the dose that the patient should be put on. So if you're sitting the GPHC exam, you might have come across some calculations in which you're calculating the renal function in order to determine the digoxin dose. In terms of side effects, one to really remember is hypokalemia. And the reason for that is hypokalemia makes the patient more susceptible to toxicity, and that's cardiac toxicity and digoxin toxicity. So it's really important that they have the correct level of potassium in the body. Some patients may be put on potassium-sparing diuretics, potassium supplements such as Sandoke, or encouraged to take potassium-rich foods such as bananas. In terms of interactions, that which increases cardiac or digoxin toxicity is when digoxin is taken with loop or thiazide and related diuretics, and that's because of the hypokalemia that can occur with both medications. And also it interacts with drugs that impair renal function, such as NSAIDs and ACE inhibitors. And that's because if renal function is impaired or an acute kidney injury occurs because of NSAIDs or ACE inhibitors, this affects the renal clearance of digoxin and therefore increases the plasma digoxin concentration in the body and can lead to toxicity. In terms of monitoring, we monitor serum electrolytes, in particular potassium, magnesium and calcium, because hypokalemia can occur, hypomagnesemia can occur, and hypercalcemia can occur, and these can potentiate toxicity. The heart rate is also monitored, and that should not fall below 60 beats per minute if you're on digoxin, and we monitor renal function. In terms of warning signs to be aware of, cardiac ones are arrhythmias and heart block. Neurological ones are confusion, lethargy, weakness, dizziness and headache. GI ones, nausea, vomiting, diarrhea and anorexia, which is unexplained weight loss, as well as abdominal pain. And visual disorders which we may see are blurred vision and yellow vision, and that is often asked in the GPHC exam. What kind of vision does a patient get if they are on digoxin and they're experiencing toxicity? And that would be yellow vision. Different formulations have different bioavailabilities, so if you're switching to from IV to oral, such as if a patient's being switched from a hospital to community setting, the dose is increased by 20 to 30%. So gentamicin is an aminoglycoside which is bactericidal, so kills bacteria. Its therapeutic range for a multiple daily dose regimen is 5 to 10 mg per litre for a peak, which is usually taken 1 hour post-dose, and less than 2 mg per litre for a trough, which is taken pre-dose. The levels are different for endocarditis, and loading doses are usually required. It's renally excreted, therefore cautioned in patients with renal impairment, and it's given IV because it's not absorbed by cells in the gut. In terms of monitoring, we monitor renal function as it can lead to nephrotoxicity, because it's renally cleared. And we also monitor auditory and vestibular function because ototoxicity, which is irreversible, can occur. In terms of warning signs, again related to the monitoring, hearing impairment can occur, and a patient may present with tinnitus, vertigo or partial hearing loss. If so, the drug needs to be stopped. And nephrotoxicity. In terms of interactions, vancomycin with the gentamicin can cause an increased risk of nephrotoxicity and ototoxicity, and if gentamicin is given with loop diuretics, that also increases the risk of ototoxicity. It's important to ensure adequate hydration pre-treatment and during treatment. So ensure the patient's drinking adequate amounts of fluid to prevent dehydration, and also to take into account any vomiting or diarrhea that the patient's having as a means of fluid loss and potential dehydration. So to compensate for that with fluids that are consumed or given. Lithium is used in the treatment of various types of mental health issues, including depression, bipolar, and mania. Its therapeutic range is 0.4 to 1 millimole per litre, and we aim for the lower end of the range for maintenance therapy and elderly patients, and the higher end of the range for acute episodes of mania or patients who have previously relapsed. Levels are taken 12 hours post-dose, and a level of more than 2 millimole per litre indicates severe overdose. It's important to stick to the same brand of lithium, as it's formulated as different salts, including lithium carbonate and citrate. So Priadel brand may be an example. and the patient also receives a lithium treatment pack. It's eliminated renally. And interactions which increase the risk of toxicity is if lithium is given with ACE inhibitors, ARBs, some of the diuretics, NSAIDs, some of the antidepressants, and metronidazole. And that's because they reduce lithium excretion and therefore increase lithium plasma levels. It also interacts with some of the anti-epileptic drugs such as phenytoin and carbamazepine to increase the risk of neurotoxicity. And there's an increased risk of extrapyramidal side effects if it's given with some antipsychotics such as risperidone, clozapine, and haloperidol. In terms of monitoring, we monitor lithium levels, renal function, cardiac function, and thyroid function tests. And warning signs of toxicity include GI disturbances such as vomiting and diarrhea, visual disturbances including blurred vision, CNS disturbances including confusion and drowsiness, tremor, which starts off as a fine tremor and increases to a coarse tremor and adopts muscle weakness, hypothyroidism, so a patient may present with unexplained fatigue, and that's a symptom of hypothyroidism, renal dysfunction, so the patient may have polyuria, incontinence, or polydipsia, which is excessive thirst, and benign intracranial hypertension, which is a persistent headache and visual disturbance. So it's not to be confused with migraine. If a patient's on lithium, this is really serious and requires urgent referral. In severe overdose, the patient may get seizures, renal and circulatory failure, they may go into a coma, or there may be sudden death. It's important to maintain constant and adequate water and salt intake whilst on lithium, and that's to avoid dehydration, which can potentiate toxicity and bring about AKI, which can impact lithium clearance. So be particularly aware during hot summer weather, or if a patient's unwell, as to them maintaining adequate water intake. In terms of salt, sodium in salt can be mistaken for lithium ions in the body and therefore compete to be cleared, so lithium levels may increase. So be aware of sodium content in Gaviscon and soluble analgesics as a source. It's also important to stress to the patient to not stop taking this medication unless advised by a doctor, and to avoid alcohol. Moving on to phenytoin. Its therapeutic range is 10 to 20 milligrams per litre, and like carbamazepine, it's an anti-epileptic drug which requires maintaining the same brand, so category 1. It has non-linear pharmacokinetics, so what that means is a small change in dose can have a drastic change in the plasma drug concentration, and similarly, if a dose is missed, it can also have a drastic change. So it's really important to stress to the patient to be compliant with the medication regimen. It's highly protein bound, and if you're sitting the GPHC exam, you may have come across some calculations which take into account protein binding whilst on phenytoin, especially in elderly patients. Side effects include coarsening of the facial appearance, acne, hirsutism, which is male-like hair growth on a female, gingival hyperplasia, so it's important to maintain good oral hygiene. So as a whole, it may not be the most suitable anti-epileptic drug in girls, especially young girls, because of these side effects. In terms of interactions, phenytoin levels may be increased when taken with trimethoprim, metronidazole, chlorothromycin, and fluconazole. And there may be a decrease in anticonvulsant effect when it's taken with some of the antidepressants and antipsychotics. Phenytoin also increases the metabolism of contraceptives, so the patient may require additional protection or switching to an alternative which is not affected by the same interaction. In terms of monitoring, we take phenytoin levels, liver function tests, full blood count, serum folate, and vitamin D levels. Also, as part of pre-treatment screening for patients of Han Chinese or Thai origin, we look for a HLA-B1502 allele, and if these patients have that allele, we avoid phenytoin as there's an increased risk of Stevens-Johnson syndrome. In terms of warning signs, so toxicity effects include diplopia, blurred vision, nystagmus, slurred speech, ataxia, and hyperglycemia, so very similar to carbamazepine. Skin disorders include rash and toxic epidermal necrolysis, which of course requires stopping treatment. Blood disorders, and we've mentioned this before, include fever, sore throat, muscle ulcers, unexplained bruising or bleeding which may be presented by the patient, and these can be signs of anemias including aplastic anemia and megaloblastic anemia. The patient may also develop suicidal thoughts whilst on phenytoin and have low vitamin D levels, and complications of that are rickets. And because there's a cross-sensitivity to carbamazepine, and because it's an anti-epileptic drug, it can also cause anti-epileptic hypersensitivity syndrome. And we've gone through the driving advice from the DVLA, so that is the same as carbamazepine. Moving on to Theophylline, which is a xanthine used in the treatment of asthma. Its therapeutic range is 10 to 20 milligrams per litre, although a lower plasma concentration may be effective, so 5 to 15 milligrams per litre. The levels are taken 4 to 6 hours post-oral modified release dose, 5 days after starting treatment or 3 days after a dose change. And loading doses may be required, and if so, this is given IV as aminophylline, which is 20 times more soluble than theophylline. It's important to maintain the same brand of theophylline because the rate of absorption can vary between different modified release preparations. So encourage the patient to check that they've received the brand that they're expecting when they're collecting from the pharmacy. Modified preparations are usually given to delay toxicity if this were to occur. Interactions: theophylline levels increase in viral infections, and they decrease in smokers and alcohol consumption. So if a patient decides to quit smoking, there may be an increase in the theophylline levels, so a dose adjustment, a reduction in dose may be needed of the theophylline. So if they do intend to quit smoking, they need to inform their GP, and if you're a pharmacist who's undertaking smoking cessation services, you need to bear this in mind as well. There's also increased risk of hypokalemia when it's given with beta-2 agonist therapies such as salbutamol. So if a patient's asthma is uncontrolled and they need to use their reliever more, so their salbutamol even more, there's an even further increased risk of hypokalemia, as well as if they need to take corticosteroids because of uncontrolled asthma and chest infections, then that can also increase the risk of hypokalemia and lead to toxicity. So it's really, really important to ensure that the patient's asthma is well controlled. There's also an increased risk of convulsions when it's given with quinolones, such as ciprofloxacin. In terms of monitoring, we monitor theophylline levels and serum potassium levels. And warning signs, so toxic effects are vomiting, which may be intractable, agitation, restlessness, hyperglycemia, as we mentioned, severe hypokalemia, convulsions, and dilated pupils. Vancomycin is a glycopeptide used to treat bacterial infections. Its therapeutic range is 10 to 15 milligrams per litre, and that's a trough level, so pre-dose, and that's usually taken after 3 or 4 doses. The levels are slightly different if you're treating endocarditis, and loading doses are usually required. It's renally excreted, and it's given orally for C. difficile infection to treat bacteria in the gut. Monitoring includes renal function tests, and that includes calculating the creatinine clearance pre-treatment, full blood count, serum potassium levels, urinalysis, and auditory function. Warning signs of ototoxicity include vertigo, tinnitus, and hearing loss, which may be signs of ototoxicity. As such, Vancomycin is cautioned in the elderly and in patients with a history of deafness. Red man syndrome, so that is flushing of the upper body, and that happens if vancomycin is administered too quickly, so the rate should not exceed 10 milligrams per minute for doses more than 500 milligrams. Blood disorders, and we've covered these, so this includes fever, sore throat, mouth ulcers, unexplained bruising or bleeding, and they may be signs of neutropenia or thrombocytopenia. Phlebitis can occur because vancomycin when injected can be irritant to the tissue. Nephrotoxicity is detected by increased serum creatinine levels. Skin disorders includes rashes and toxic epidermal necrolysis. And anaphylaxis and hypotension can occur if it's administered too quickly as well. Interactions, and these overlap with the gentamicin slide. There's an increased risk of nephrotoxicity and ototoxicity when vancomycin is given with aminoglycosides, and an increased risk of ototoxicity when it's given with loop diuretics. And finally, warfarin, which is an oral anticoagulant and a vitamin K antagonist. Its therapeutic range is according to the indication and the set international normalized ratio for that indication. So it's according to the INR, which is how quickly the blood clots compared to normal, and a normal value is 1. So if a patient has a high INR, they're at an increased risk of bleeding, and if they have a low INR, they're at an increased risk of a clot. So as examples, a target INR of 2.5 is for the treatment of DVT and PE, or of atrial fibrillation, and a target INR of 3.5 is set for recurrent DVTs and PEs. And the reason for that is these patients who are being treated for those conditions are at an increased risk of clotting, or you're trying to prevent a clot from occurring, so you're increasing the INR to prevent clotting happening. The INR is taken at least every 3 months, or more frequently if the patient's just received a high or low INR compared to their target. It's also taken more frequently in acute illness, vomiting, diarrhea, medication or diet changes, or signs or symptoms of bleeding and thrombosis. Be aware that it takes 48 to 72 hours for an anticoagulant effect to fully develop with warfarin, so in newly started patients on warfarin, bear in mind that their first day of readings may be inaccurate. The patient's given an oral anticoagulant pack, and they should be encouraged to carry around their record booklet and their alert card so that they can report their INRs when they're collecting from the pharmacy, and also let their dentist know that they're on an oral anticoagulant. Monitoring includes clotting screen, liver function tests, renal function, full blood count, blood pressure, and thyroid function tests. Warning signs include hemorrhage, so excessive bleeding, and that may be from nosebleeds or wounds. Thrombosis, so a clot, and that would be expressed as pain, swelling, redness, and tenderness in the calf if it's a DVT, so a deep vein thrombosis. And if it's a pulmonary embolism, they would experience chest pain and shortness of breath. The patient may get rash, purple toes, headaches, and diarrhea and vomiting. And with diarrhea and vomiting, that can lead to poor absorption of the medication, and that's why more frequent INR monitoring is required. Interactions, so those which increase anticoagulant effect is with cranberry juice and NSAIDs, and the way I've taught my pre-reg is to remember which juice interacts with warfarin is cranberry is red, warfarin acts in the blood, so red, cranberry and warfarin. There's a decreased anticoagulant effect with green leafy vegetables as they contain vitamin K, and warfarin's a vitamin K antagonist. It's important to take warfarin at the same time each day. This is usually around 6 p.m. in community, but in hospital it changes to 2 p.m. for the ease of administration. It's important not to double the dose, so if a patient forgets to take a tablet, leave that one out and take the next one as normal. They should notify the clinic of changes to diet or medications. And it's important to be aware of tablet colours. So for the patient, they should be aware so that they're making up the correct dose from their tablets. And for the pharmacist or pharmacy staff, they should be aware, because if a patient says, I'm taking this colour tablet, then you should know what strength that tablet is. So that's all for our narrow therapeutic index drugs. I hope you found this video informative and useful in your revision. And if you have any feedback, please let us know, and keep an eye on our Instagram page where you can vote for your next topic. Thank you.